buccinator and zygomaticus muscle. Then here is marginal mandibular branch innervate the mentalis. Then cervical branch, it innervates the platysma. This flat muscle of neck is the platysma. Okay, so these are the 5 branch and they are supplying muscles. Okay, understood? So you have to remember this 5 branch. Very frequently asked in your Viva, what are the 5 terminal branches? Next, 5 branches have been shown: temporal, zygomatic, buccal, marginal mandibular, and cervical. Okay, here is the posterior auricular. After coming out from this stylomastoid foramen, first branch is posterior auricular. After that, it entering into this parotid gland, and within the substance of parotid gland, it is dividing into 5 terminal branches. Okay, understood? 3 structures are lying within the substance of parotid gland: retromandibular vein, carotid artery, and this facial nerve. Okay, 3 lies in 3 planes. Superficial most is the facial nerve. Okay, understood? Next. So facial nerve does not supply the skin. Sensory supply of face, it is carried by the branches of the trigeminal nerve. That also we will discuss today. But its branches communicate with the branches of trigeminal nerve. Okay. Next, nerve fibers of the facial muscles leave the facial nerve in these communicating branches and pass to the central nervous system via the trigeminal nerve. Okay, so mainly all the sensations, pain, touch, temperature, and also the proprioceptive sensation from the muscles, all these are carried by branches from the trigeminal nerve. Okay, next. Okay, now we will discuss the extracranial course of the facial nerve. So it supplies the muscles of facial expression with its motor fibers, and the muscles receive its sensory and proprioceptive fibers from the nerve, supplying the overlying skin, that is the trigeminal nerve. Next, the nerve emerges from the base of the skull through the stylomastoid foramen near the origin of the posterior belly of the digastric muscle. Okay, here it is coming out, and this is posterior belly of the digastric muscle. Okay. Next, so from after coming out through the stylomastoid foramen, first branch is posterior auricular nerve. It passes upward behind the ear to supply the occipital belly of the occipital frontalis. Here, this branch is going posterior on the posterior aspect of the ear, supplying the auricularis posterior and occipital belly of the occipital frontalis. Next चलेगा. Okay, now it is giving the muscular branches supplying the face. Divide to supply the posterior belly of digastric and stylohyoid. Okay, and the nerve then approaches the posteromedial surface of the parotid gland and divide into, first it divides into 2 branches, and these 2 branches again divide into total 5 branches: upper temporozygomatic and lower cervicofacial. Okay. Here it is entering into the gland. Gland has been cut partially to show the nerve fibers. Next. Okay, within the parotid, it divide and redivide and lies superficial to the retromandibular vein and the external carotid artery. This position is also asked. Okay. So it is superficial most, facial nerve. That's why in case of injury over the face, over the parotid region, any cut injury or something, there is high chance of injury to this facial nerve branches. Okay, and paralysis of facial muscles. Next, we discuss the individual branches. First is temporal branch. It emerges from the upper border of the parotid, cross the arch, and supply the auricularis anterior and superior, and part of the frontalis, and wrinkling of the forehead. That means corrugator superciliary. Okay, all these are supplied by the temporal branch. Here in this region it is supplying temporal branch. Next, next, next is zygomatic branches. Here in this region over the zygomatic arch lies this zygomatic branch. It has upper and lower branches, passes above and below the eye. The upper supplies the arteries, the upper half of orbicularis oculi, and the lower supplies the lower part of orbicularis oculi and the upper and lower eyelid. Paralysis of this branch prevents the blinking of the eye and the spreading of tear film and leads to dryness of the cornea, and there will be ulceration. If dryness occurs, there will be ulceration. Next, okay, next is buccal branches. Buccal branches supply the buccinator and the muscle fibers of the upper lip, orbicularis oris, and lower part of the elevator muscles. Paralysis affects the emptying of the cheek pouch. Okay, this buccinator muscle was helping in emptying of the cheek pouch. That means vestibule, emptying of the vestibule of the mouth. So, in case of paralysis of this branch, there will be loss of emptying of the cheek pouch. Okay. Next is marginal mandibular nerve. Okay, here in this region it is like this is buccal nerve, and this is the marginal mandibular, and here is the cervical. So marginal mandibular emerges from the lower border of the parotid gland, pass into the neck below the angle of the mandible, crosses the inferior border of the mandible at the anterior border of the masseter muscle over the facial artery. Here, this is masseter muscle. Here it is crossing the inferior border of the mandible. Okay. Here also enters into the face the facial artery. Okay. And this nerve is a very fine nerve and lies over the facial artery in this region. And they supply the muscles of the lower lip. Marginal mandibular branch supply the muscles of the lower lip. Next, and paralysis of this branch leads to paralysis of the lower lip. Next, it passes vertically downward from the lower border of the parotid. See, this is the cervical branch. It passes vertically downward, and from the lower border of the parotid behind the mandible to supply the platysma muscle. So it will supply the platysma. This one, not this here. This is the cervical branch. Next is supply the skin of the face, except the angle of the mandible is supplied by 3 branches of the trigeminal nerve. Next, we are going to the sensory supply of the face. Up till this, we were discussing the motor supply. Okay, facial nerve is the motor supply of the face. Next, we are going to the sensory supply. Sensory supply of the face, skin of the face except the angle of the mandible is supplied by 3 branches of the trigeminal nerve. Next, it is the trigeminal nerve is divided into 3 zones. The face is divided into 3 zones according to the supply by the 3 divisions of the trigeminal nerve. So, these lines of division, first upper line passes through from the lateral angle of the eye, okay, extends upward and laterally, and next line passes from the lateral angle of the mouth and meets the first line and passes upward and laterally. Okay, so this upper area Above the upper line, this part is supplied by the ophthalmic division. This pink area is supplied by the maxillary division, and this area is supplied by the mandibular division of the trigeminal nerve. And they are supplied according to their development. Okay, all these three areas are developed from three processes which helps in development of the face. Face develops from three processes: frontonasal process, maxillary process, mandibular process. The area formed by frontonasal process is supplied by ophthalmic nerve. The part formed by the maxillary process supplied by the maxillary nerve, and this part formed by the mandibular process is supplied by the mandibular nerve. Okay. So that's how the supply is coming. So it is divided into three zones by line above the margin of the eyelid and another at the angle of the mouth, and the lines curve upward and backward. And the muscles are supplied with proprioceptive fibers from the same cutaneous nerve. Okay. Next. So these three branches again giving some smaller branches. Okay. So ophthalmic division has 5 cutaneous branches. Okay. These are the 5 cutaneous branches: supraorbital, supratrochlear, lacrimal, infratrochlear, and external nasal. These 5 are branches of ophthalmic division. Next is maxillary division. It has 3 cutaneous branches: zygomaticotemporal, zygomaticofacial, and infraorbital. These three are branch of the maxillary division. Then mandibular division, buccal, mental, and the auricular branches. Okay, this buccal, mental, and this great auricular branch, this is coming directly from the cervical plexus. Okay. So all these are coming from the mandibular division. Next, see the three branching pattern of the trigeminal nerve. Here is the trigeminal ganglion is lying here. From here, 3 branches are coming out. Upper one is ophthalmic, here is maxillary, and this is mandibular, and it's supplying the corresponding area. And these are the different branches of this 3 divisions. Here is supraorbital, supratrochlear, lacrimal, infratrochlear, external nasal. These 5 are branched from the ophthalmic division. Then maxillary division, infraorbital, zygomaticotemporal, and zygomaticofacial. Okay, these 3 are division of this maxillary division. Here is branch from the mandibular division, buccal and mental. Buccal, mental, and here is the auriculotemporal. These 3 are division from the mandibular division. Okay. Next. So this is area of distribution, red colored area supplied by ophthalmic nerve. Maxillary, you practice a schematic diagram like this. Okay. Maxillary division, blue colored area is supplied by maxillary division, and green colored area is supplied by the mandibular division. Okay, and these are the branches. Here you can, this red colored one is ophthalmic division. So ophthalmic nerve supplies the skin of the forehead, upper eyelid, the conjunctiva, and the side of the nose down up to the its tip, and it gives 5 branches of the nerve pass to the skin. 5 branches you have discussed, okay, in the previous picture. Next. So now we will discuss 5 branches of the ophthalmic division. Okay. First is lacrimal nerve. It supplies small area of the skin over the lateral part of the lower eyelid here. Here lies the lacrimal nerve. Okay. Next is supraorbital nerve. Here, this is supraorbital nerve. Along the supraorbital ridge, there is a foramen at the junction of medial 1/3 and lateral 2/3, and through this foramen passes this supraorbital nerve. Okay. So it emerges through a foramen towards the medial end of the upper orbital margin, passes upward and divide into many branches and supply the forehead and the scalp up to the vertex. So this is supraorbital nerve. Next is supratrochlear. This medial to the supraorbital will be the supratrochlear nerve. Medial to the supraorbital emerges from the frontal foramen and supply the middle of the forehead up to the hairline. Okay, so this is the supply. Next is infratrochlear. Here, this one is the infratrochlear nerve. Supply the skin on the medial part of the upper eyelid and over the bridge of the nose. This part is known as bridge of the nose. Okay, medial part of upper eyelid and bridge of the nose. Next, अच्छा, previous okay. So all the previous 4 divisions are supplying the upper eyelid and the conjunctiva. Okay. Next is external nasal nerve. Okay. Here is the external nasal. It emerges between the nasal bone and the upper nasal cartilage, and it supplies the middle of the external nose down to the tip. Okay. So this is the supplying area here near the tip of the nose. Next we go to the previous one, maxillary nerve. Okay, maxillary, this bluish colored area is supplied by the maxillary nerve. Maxillary nerve supplies the skin on the posterior part of the side of the nose. Okay, here this part, posterior part of side of the nose, the lower eyelid here, lower eyelid and the cheek, upper lip here, upper lip and the lateral side of the orbital opening here, lateral side of the orbital opening. All these areas are supplied by the maxillary nerve. 3 branches of the nerve pass to the skin. Okay, 3 branches are zygomaticofacial, zygomaticotemporal and infraorbital. See, infraorbital, and over the zygomatic bone lies the zygomaticofacial and zygomaticotemporal. Next, first we will discuss the infraorbital nerve. It passes through the foramen and lies between, say here is the infraorbital foramen, below almost 1 centimeter below the infraorbital margin. Okay, so it emerges through this infraorbital foramen and lie between the levator levi superioris and levator anguli oris, and palpebral branches supplying the lower eyelid and the cheek. Here is supplying lower eyelid and cheek. Nasal branches supplies the sides and along the nose. Here, these are the nasal branches. And labial branches supplying the upper lip and labial gum. Here, this labial branches supply upper lip and the labial gum. Next is zygomaticofacial foramen on the outer surface of the zygomatic bone. Here, this is zygomaticofacial and supply the overlying skin of the cheek mainly. Next is zygomaticotemporal. Here, it emerges in the temporal fossa. Okay, temporal fossa from the zygomatic bone and supply the skin over the front of the temple. See here, supplying skin over the front of the temple on a level with the upper eyelid and the hairless part of the temple. Okay, so this is supplying area of zygomaticotemporal. Next, so 3 divisions of the maxillary nerve we have discussed. Now, next we will go to the mandibular division. Okay, mandibular division. See, this green colored area is supplied by the mandibular division. It supplies the skin of the lower lip, lower part of the face, here, lower lip, lower part of the face, the temporal region here, temporal region, and the part of the auricle here, some part of the auricle. It then passes upward to the side of the scalp, going to the side of the scalp. Okay. mainly the auriculotemporal branch from this mandibular division. Next, three here also it is also giving three branches of the nerve pass to the skin. Next, first is auriculotemporal nerve here. This one is auriculotemporal. Pass behind the neck of the condyle of the mandible, okay, and ascend over the root of the zygoma behind the superficial temporal vessels. During face dissection, you will see this auriculotemporal nerve and the superficial temporal vessels are lying together. Okay. Next, the auricular part supply the external auditory meatus, skin of the auricle and tympanic membrane. Next, and the temporal part, it supplies the hairy skin over the temple. Next, next two branches are buccal nerve and mental nerve. Okay, long buccal nerve, they supply the skin of the cheek under the zygomatic bone, and mental nerve, it break into tufts of small branches, supply the skin of the mucous membrane of the lower lip and the labial gum to the lower premolar teeth here. By the mental foramen, it is coming out. Okay, here is the mental foramen of the mandible. You have read during the bone of mandible. So it is coming out through the mental foramen, skin and mucous membrane of the lower lip and the labial gum to the lower premolar teeth. Next, only a small part is supplied by branch from the cervical plexus near the angle of the mandible. Okay, greater auricular nerve is supplying this area. C2, C3 nerve fibers pass vertically over the sternocleidomastoid, supply the skin on the face over the angle of the mandible, the parotid and its fossa, and the auricle, its cranial surface, and the lower part of the lateral surface. Okay. All these areas are supplied by greater auricular nerve. Next, previous one. Next, we will go to the Bell's palsy, facial nerve paralysis. Okay, what is its etiology? What is the presentation? Its diagnosis, treatment, like this. Okay. Next, it comes as a short note, Bell's palsy. Okay, and nerve supply of the face is also important short note. Okay, you have to write both motor supply by facial nerve branches and sensory supply. Okay, branches from the trigeminal nerve, or also it can come separately, motor supply of the face or sensory supply of the face, to prepare as a short note all these things. Okay. So Bell's palsy, its definition, it is an abrupt, unilateral, isolated facial nerve paralysis. Okay, mainly lower motor neuron type of paralysis. One of the most common neurological disorder of the cranial nerves. There is no detectable cause for such a disorder. Okay, mainly idiopathic. Okay, idiopathic means there is no specific reason. Next, it is considered idiopathic in origin. However, these infections may be strongly associated with this facial palsy. Infection with these viruses like herpes simplex virus, herpes zoster, and more common in diabetic patients during pregnancy, infection by Epstein-Barr virus or hereditary factors may play a role. Okay, in this etiology of this Bell's palsy. Okay, understood? Next, mainly unknown cause. Okay, but a popular theory proposed that reactivation of herpes simplex virus cause inflammation, ischemia, and demyelination of the facial nerve, and which can alter the sensory and motor function of the facial nerve. An increased incidence of Bell's palsy was also reported among recipients of inactivated intranasal messenger vaccine. Okay, this reactivated virus that may be activated, okay, during due course, and it may affect the facial nerve. Next, now how will you diagnose it? Diagnosis that is such a disorder is purely clinical diagnosis mainly. Okay. Electrodiagnostic test, it is done in 14 days, provide information about the prognosis of the disease. Next, these two tests are mainly done. Nerve excitability test, it determines the excitation threshold by recording the minimum electrical stimulus required to provide visible muscle contraction and compare the action potential between the affected side and the healthy side. Another is trigeminal blink reflex. It measures the intracranial pathway of the facial nerve. Also useful test to study various post-paralysis sequelae such as synkinesis and hemifacial spasms. Okay. Next, epidemiology. Okay. Base palsy is one of the most common facial disorder, affects both men and women. Common in age group 10 to 14 years. And the great occurrence has been noted in Japan, Mexico, Israel. However, the incidence varies in different parts of the world. Also very frequent in India in nowadays. Okay. Okay, regarding the seasonal onset, the disease incidents are more during autumn season, followed by the winter season. And this disease are more common between the ages of 10 to 30 years. Okay, this age group is mainly affected. Next, but in diabetic patients, it occur in older ages mainly after 50 or like this. Okay. When there is uncontrolled diabetes, there is high risk of this facial pulse. Okay, so what will be the clinical features? Okay, you have to know the signs and the symptoms. So, these are the symptoms. Patient will complain this. Okay, you have to write it down like this. First, symptoms and signs, you have to write it differently. You know us, what is symptom, what is sign? Symptom, what the patient complains. Okay, and signs, you have to find out. Okay, so what will be the symptoms? There may be aching pain in or around the ear precede the onset. Okay, near the ear there will be pain. Inability to express the normal facial expressions, pain on the side of the face, and impaired taste sensation on the anterior portion of the tongue. Okay, anterior portion of the tongue, taste sensation is carried by cauda tympani nerve. Cauda tympani nerve is branched from facial nerve. That is also involved. Okay. Next, these are the signs: drooping of the eyelid, decreased dryness of the ear, excessive tearing. There is eyes. The patient cannot close the eye properly. Okay, that's why the tear fluid is overflowing. There will be twitching or weakness on the affected side, loss of the nasolabial folds, drooping of the angle of the mouth, corner of the mouth, and there will be dry mouth. Okay, dry mouth because less salivary secretion. Okay. Next, so these will be the signs. Okay, signs you have to write down all those according to points. Now, what is the treatment? No specific treatment for Bell's palsy. Mainly corticosteroids are given, antiviral agents if there is diagnosis of infection of some of those virus, herpes zoster, Epstein-Barr like this, and physical therapy, various physical therapies such as exercise, facial exercise, biofeedback, laser, electrotherapy, massage and thermotherapy. All these can be given. Eye care includes eye patching and lubrication. Okay, artificial teardrops are given and covering the eye. Okay, because there is patient is unable to close the eye properly. And surgical treatment, if there is compression you detect in the course of the nerve, you have to decompress the nerve. Next, what is the prognosis? Okay. Study shows that about more than two-thirds of the patients with Bell's palsy achieve full spontaneous recovery. In 85% of people show improvement within 3 weeks of onset, and on the other 15% some improvement occurred between 3 to 6 months later. And in the same patient, 71% of them recovered the normal facial function and appearance. Okay, so this is the recovery rate, prognosis of this Bell's palsy. Next, so until now there is no absolute etiology of Bell's palsy. Clinical presentation varies patient to patient according to partial and complete palsy of the nerve. And regarding the prognosis, Bell's palsy show great number of patients recovery and most of them within 3 weeks. Okay, and restoring the normal facial appearance varies. However, most of the cases show full facial appearance recovery. And the treatment is not specific, but as mentioned, some treatment found to be effective. Okay, mainly corticosteroid therapy is given. Okay, and some vitamins. Vitamin B12 is generally given. Okay. Okay, so that's all about the Bell's palsy. Next. Okay, that's all. Any queries regarding today's topics? So you prepare the sensory supply and motor supply of the face as a short note. Okay. Mainly the motor, this comes, motor supply is also asked in your viva, branches of facial nerve, and also you prepare Bell's palsy, very commonly given short note. Okay, Bell's palsy. This will also come in your final year also. Okay, any queries? Okay, that's all. Thank you.
Hypothyroidism cases, and maybe some of your family members or somebody else relatives might be suffering from hypothyroidism, because this is a quite common disease and being diagnosed very early nowadays because of the investigation facilities throughout everywhere. Practically blood collection centers are available everywhere. So this disease is detected much earlier than what was used to be done in the past, maybe before 2000 or 2010 also. So in your syllabus, this particular aspect has been written now from today's onward class, and basically emphasize on what is the actual topic which you are supposed to know. See, there is the red letter word. One is explain, that's most important, and second is basis and rationale. Third one is biochemical test, and fourth one is thyroid disorders. Now, without knowing these thyroid disorders, without knowing the basis of thyroid diseases, without knowing the basis of thyroid functions at the basic level, it is very difficult to realize or understand. Forget about realization, this is a much later stage. To understand the biochemical test, and then only you will know what is the basis and rationale, and then only you will be able to explain why you are doing it. So fundamental knowledge about thyroid functioning, that how thyroid hormone operates and produces effects in our body, you must know. I'll try to cover within 1 hour, but it is not sufficient. If you require any more class, I'll be happy to take it because this was my PhD topic. So I can tell you at length, maybe full 1 day, to So without wasting much time, তুমি কোথায় গেলে ছেলেটা? এই তো মুশকিল হয় না, পালিয়ে যায়। The location of the thyroid gland. It is in front of the skin, just below the laryngeal prominence or thyroid cartilage. There is cricoid cartilage, and the thyroid gland is located just below that. This isthmus. See, this is the actual position, and this is one of my patients. Her mother suffered from thyroid diseases, and I have been following up since her birth. Now you can see in the beginning, when she was a child, you cannot see any swelling here. But with the passage of time, now she has developed goiter, and that's a problem. See, anybody suffering from thyroid disease with goiter, particularly mother, you need to follow up, and photography is the best thing to document it date-wise and show the video. In the early part, when she was a second year, I noted it, and you allow a water to be deglutated so that you can see the movement. Next, just observe. Can you see the gland? This is very much visible. So somebody is sitting in front of you, just simply look at the third one, it will be much more prominent. See, gradually look, it is moving with the swelling, with the deglutition. So when somebody is present in front of you, just by looking at it on the neck, you will be able to diagnose whether the patient is having an enlarged goiter. This enlargement of goiter may be associated with normal functioning. It can be associated with the hypofunctioning and also hyperfunctioning. So, and the patient might be also under treatment. Next, here presentation. And it is start করে চলে যাও, এগিয়ে যাও, তিনটে স্লাইড বলে দিয়েছি। চলো পরেরটা। হ্যাঁ, see some important information about thyroid. See, daily requirement of iron is 150 microgram, and in pregnancy everything is requirement is increased because of the growing fetus. So is iron also. So it is increased in iron, and iron is present in the drinking water. And the locally grown foods or the animals living on that plant, they actually have iron from the soil itself. So high amount is present in the sea fish, sea salt. However, we get a major amount of iron from dietary sources, from cereals, from vegetables, and smaller amount come from milk, meat, vegetables, and cereals. And 90% of the iron requirement is usually met up by the food, and rest from drinking water. Now, iron content of the soil in any area is the determinant of iron deficiency in that particular area. And throughout the world, iron is a scarce element, and that's why nature has evolved mechanism to preserve iron as much as it can economically use it also. So iron content of the soil is the major determinant of iron content of the water and locally grown foods, and accordingly presence of iron, availability of iron within our body. So iron deficiency is basically geochemical in nature. In the high areas of mountain and certain areas of geographical area are deficient in iodine, and they suffer from iodine deficiency disorders. And this said there is a spectrum of diseases of iodine deficiency disorders about which you will read later. See, right from when the baby is within the womb, there will be poor development, congenital malformation, chances of abortion, increased perinatal mortality rate, neonatal hypothyroidism, neonatal goiter, and even in the adult life also one can suffer from goiter and also hypothyroidism because of the lack of iodine. So 80% of the total iodine is stored within the thyroid gland. In the 8th plan, which started in 1992, 8th 5-year plan, Government of India made a policy that iodization of the salt is a mandatory thing, and by the end of the 5th year, iodization of the salt will be available, will be made available, and during our MBBS life, this iodized salt was not available. We used to get salts which are packed in jute sack bags, but from mid-85, iodized salts were available in the market, and from 2000, practically that sack salt, jute sack salt is not seen, and everywhere you will get this salt available in the packets, and that is iodized salt. And many companies are producing iodized salt. Just for information, I have shown this slide. So if you look at this iodine content, it is 2 grams per 100 grams. This 2 grams is 2000 microgram per 100 grams. So 1 gram contains 20 microgram. WHO recommends salt intake of less than 5 grams per day. So usually we take 3 to 4 grams of salt along with our food. So average consumption of iodine from salt itself constitutes 60 to 80 microgram. So ideally there cannot be any deficiency, because iodine is supplied from the salt. In addition, we are getting iodine from water and also from food. So these are the total 11 steps at least you have to memorize. One is iodine we take as iodide, not as iodine. So that iodide is absorbed by the intestine through a sodium iodide symporter. It's an active transport procedure against the concentration gradient, and it is taken up by the enterocytes and released into the circulation, from where again that iodine is actively taken up by the thyroid gland, which I will tell you later. It's an energy dependent process. So uptake of iodine by the thyroid gland is the first step of iodine thyroid hormone synthesis. Now then comes the oxidation of iodine. Iodine is present in as iodide, it needs to be oxidized to elemental iodine, and then iodination of the thyroglobulin present in the thyroid follicle, and then there will be formation of monoiodotyrosine and diiodotyrosine, and then coupling reaction, then that will be stored in the thyroid, and then it will be utilized, and later it will be released also in the circulation, and it will be transported through the peripheral tissues, where it will exert its function, and finally again these hormones will be excreted through liver by conjugation with glucuronic acid. Each and every step I will be telling you, and you must remember all these 11 steps, because this is important for examination, how thyroid hormone is produced. So formation of thyroid hormone, first step, as I told you, it's uptake of iodine from blood and concentration by the thyroid. Its iodide is taken up by the thyroid gland against a strong electrochemical gradient, because the concentration of iodine in the blood is less, and thyroid gland can take up iodine very avidly through that sodium iodide transporter, and the concentration of iodine within thyroid is 25 times more than what is present in the serum in a normal dietary supply. But when this gland is chronically stimulated by TSH, this ratio can go up to 500:1 in experimental animals. So thyroid is having a tremendous capacity of uptaking iodine from the circulation. So it's an energy dependent process. So sodium potassium ATP pumped is linked to sodium iodide transporter. This step is stimulated by the TSH secreted from the pituitary gland, and this step is again experimentally inhibited by thiocyanate and perchlorate. Next. Now, second step is oxidation of iodine. This step is carried out by thyroperoxidase. It requires hydrogen peroxide, and that is obtained through NADPH enzyme, which is cytochrome C reductase. Is somewhat resembling that enzyme from where this hydrogen peroxide is obtained, and this iodine is converted into elemental iodine, and then only it can be organified. So, basically iodine is an inorganic molecule, and in order to preserve it within our body, store it and economically use it, it is organified, that is incorporated within the organic molecule, that is a thyroglobulin molecule, which I will tell you. So, this state is stimulated by TSH, and it is inhibited by the anti-thyroid drugs, and that I will discuss, because when the patient suffer from hyperthyroidism, anti-thyroid drugs are given, and that anti-thyroid drug inhibits this step. So, further steps cannot take place, and obviously less thyroid hormones will be produced. So, once this iodine is taken up by that thyroglobulin, it cannot come out of the thyroid so easily. So, basic purpose is to store that iodine which has been taken along with the diet as a reserve. So, thyroglobulin colloid in the thyroid acts as a large reservoir of thyroid precursors. Next, so iodination, this is another step. So, it is thyroglobulin molecule which is iodinated. It is a 660 kilodalton protein, it's a large protein having 5000 amino acids with 115 tyrosine residue, and this tyrosine residue gets iodinated. And in a thyroglobulin molecule, usually 35 tyrosine is iodinated of the thyroglobulin molecule, and once this, if two iodine are, it's one iodine is, there is a one iodination by the tyrosine molecule, that is called monoiodotyrosine, and if two iodine is there, are there in the tyrosine molecule, that is called diiodotyrosine. And one molecule of MIT and one molecule of DIT will make triiodotyrosine, because 3 iodides are there, and 2 molecules of DIT, that is diiodotyrosine, will form T4, that is thyroxine. Next. So, coupling. So, basically after that has been formed, there is a coupling reaction. So, 2 molecules of diiodotyrosine, that means there is a 4 iodine atom, and this step is done in the thyroid gland. Basically 100% of the thyroid gland is produced, the thyroxine is produced by the thyroid gland and not by the peripheral tissue. In contrast, only 20% of the triiodothyroid is produced by the thyroid, rest 80% is done from the peripheral conversion from T4 to T3. So, I repeat, try to remember 100% of iodine, thyroxine is produced by the thyroid gland. In contrast, 80% of the triiodothyroid is produced by the peripheral tissue through deiodination reactions from T4, and 20% of triiodothyroid is formed from the thyroid gland. So, basically T4 is a pro-hormone from which another hormone is produced, that is triiodothyronine. So, this is again under control of TSH to hypothalamus, and this is controlled by the blood levels of T3, T4, how much TSH will be produced. Next. So, storage. So, that is another thing that, as I told you, it is a scarce element. So, this thyroid gland remains stored within the follicle, and that storage can supply thyroid hormones for several weeks, because so much of a large molecule, so many amino acids are there, and it can meet up at times of crisis when there is iron deficiency. And then utilization, basically thyroid it will be taken up once the thyroglobulin molecule is formed. It is taken up by the acinar cells and through a process called pinocytosis, and there is a fusion between that particular vesicle with lysosome, and there is increased phagolysosome activity. So, because of that thing, there is a hydrolysis of T4 by specific protease, and that is influenced again by the TSH. Next part. So, release T4 is released into the bloodstream. See, as I told you, the iodine is a scarce element, so body has evolved a mechanism. Whatever amount of MIT and DIT has been formed, that could not be coupled either to T4 or to T3 is deionized, and that iodine is recycled within the thyroid acinar cells. So, that is a salvaging of iodine. Iodine is saved from being wasted. That is the reason why it is called the salvage. Now, this iodine, this thyroxine, as you see the structure of the thyroxine is basically there is a feather-like ring. It is not that water soluble, so it requires a transport protein, and T4 is transported maximally by there is a specific globulin, that is thyroxine binding globulin, and that carries 80% of the thyroxine, and rest is of the thyroxine is carried by albumin. Albumin carries a number of molecules, and T3, T4 are also no exception, and there is also an element called TBPA, that is thyroxine binding pre-albumin. It is called transthyretin also. Now, as I told you that once it goes into the peripheral circulation, it exerts its action, metabolic actions, and then after that job is accomplished, it is taken up by the liver, where it is conjugated with the glucuronic acid, and then it is excreted through bile, just like bilirubin. Next quarter. So, synthesis of the steroid gland, schematically I have shown it, that iodine is taken up by the blood. This is capillary side, this is thyrocyte, and there is the colloid side, colloid follicle. So, it is taken up by the iodine, trapped in the thyroid follicular cell, that is acinar cell, at the basolateral surface. You see, this is the surface within the cell, that is the basal surface where this MIT and DIT is formed, and thyroid peroxidase is present here in this area. And then it is, again I told you, once it is formed, this T3, T4 is formed, then it is, there is actually pinocytosis by the these cells, and this will fusion with the lysosome, and this will undergo hydrolysis, and T3 and T4 will be released. This is another schematic diagram, better representation to show that how iodine is transported from the blood, and it is processed within the thyroid follicular cell, and finally it is released into the circulation. Next. So, anti-thyroid drugs which you will be using in clinical practice. Remember these two drugs, name of the drug which you will be requiring for every hyperthyroid patient, that is carbimazole. And the mechanism of action of carbimazole is to reduce thyroid production, hormone production, and it is done by inhibiting the function of the thyroid peroxidase enzyme. So, there will be no oxidation, so there will be reduced oxidation, and of course, that will be reduced organification. So, thyroid hormone will not be produced, or if it will be produced, it will be produced in very significantly less amount. Now, normally propyl thyroxine uracil is not given. So, at times this may be required to be given, and peripheral propyl thyroxine in addition inhibits deiodination, peripheral deiodination from T4 to T3. Try to remember this particular point, that how carbimazole actually acts. And as I told you, the biochemistry will be required in pharmacology, in medicine, there is no escape out of it, and this particular step will be inhibited. So, this is again a schematic diagram. Next. So, this is again a schematic diagram showing how thyroid is that produced and it is released. you see that sodium iodide transporter, remember one thing, a sodium iodide transporter is there to actively transport iodide from blood into the system. It's an energy dependent process. It requires sodium potassium ATP pump. So some energy is definitely wasted or expended for expenditure of energy is there also for taking up iodine by the thyroid gland. Next. So in the circulation, thyroid remains in two forms. One is total form, that is in the bound form as the TBG, this is albumin or TBPA, and there is a free form, and free form is the active form. And from this picture you can see how much is the bound form. This T3 is only 0.3% free, and that is the active form. Similarly, T4 it is 0.03% is free, and that exerts action. So that free form and the bound form is in total dynamic equilibrium. So when there is less supply of free T4 from the stored amount of huge amount of bound form, some amount is released to become available to be biologically active. So ideally there cannot be a deficiency, there is a high amount of protective mechanism within the body not to suffer from any deficiency, but it does occur if the disease state continues for quite some time. So T4, as I told you, it's a pro-hormone, it is synthesized almost exclusively by the thyroid gland, and it is having a half-life of 4 to 7 days. This is clinically important because in practice you will be prescribing thyroxine hormone, and then re-evaluation will be required, and basically for any drug you must remember the half-life of that particular drug, and that is pharmacokinetically most important thing to determine the dose interval and also changing the drugs also. In contrast, T3 is having a only 1 day half-life. Next. So there are several differences between T3 and T4. Out of these points, I want you to remember only these points which are written in the red. So T3 is more than 3 times active than thyroid. T4, that you must remember. Which one is the most metabolically active form? It is a T3, which is metabolically much more active than the thyroid gland, and in the periphery. Basically, T4 is converted to T3, and T3 exerts its action, and it is the T3 and T4 both combined, they regulate the THC secretion. So relative metabolic potency, you must remember that T3 is metabolically much more potent, and serum half-life is 7 days. In contrast, it is T3. T3 is not administered pharmacologically in patients, but T4. So you must know P's and Q's of T4. And fraction directly obtained from the thyroid gland is, as I told you, this is 100%, this is 20%. That you must remember. Next one. So regulation of secretion. একটা চক দাও তো, পরে ছবিটা দেখো, পরে পিকচারটা দাও। This is pituitary. এটা ভালো চক নাই। The report. So normally from hypothalamus TRH is released. Thyroid releasing hormone TRH is produced by the hypothalamus. Thyroid releasing hormone, and on the pituitary to form TSH. TSH, thyroid stimulating hormone, is released by the pituitary, and this thyroid TSH acts on the thyroid gland, and it stimulates the thyroid gland to produce thyroid hormones. As I told you, it is under the influence of TSH. So under the influence of the TSH, the acinar cells produces thyroid gland, or it actively take up iodine also. So from thyroid you get T3 and T4 and T3. from T4, T3 is produced, and normally there is a normal level of TSH, TRH, normal level of TSH and normal level of T3 and T4. So when there is a less production of T3 and T4, it will stimulate hypothalamus to release more TRH as a compensatory mechanism to increase more production of TSH. This T3, basically T3 exerts its effect on hypothalamus to produce more TRH and then to more TSH. So when thyroid is hypofunctioning, that means less amount of T3 and T4 is produced. So that will that is exerting an inhibitory response, stimulatory response to hypothalamus and pituitary to produce more TSH, and this is the basis why TSH level is very high, and that is a compensatory stage. Remember, when the compensation will be adequate, there will be adequate production of T3 and T4, and although TSH level will be high, the body will not suffer from any kind of thyroid hormone deficiency, but biochemically TSH level will be high, and that indicates that thyroid, pituitary, hypothalamus, pituitary and thyroid axis is functioning normally. So there is a limit for everything. When there will be exhausted, so a huge amount of TSH will be produced, but if the gland doesn't function, and that happens, the thyroid hypothyroidism develops over a period of years. It's not a single day disease. It doesn't occur abruptly until the thyroid gland is removed surgically. So that occurs over a period of time, and with the gradual destruction of the thyroid gland, there will be progressive decrease of the T3 and T4, and that will progressively increase TRH, progressively increase TSH. So there will be gradual increase of TSH level with the passage of time, and the T3, T4 level will be decreased. And in the initial stage, the F3, T4 and F3, T3 level will be decreased, not the total, because the total form is in the 99.9% or 99.97% are bound. So there is a huge reservoir. So if you look at the total hormone level will not be decreased, only the FT3 and FT4 portion will be released. In contrast, again, if the T3, T4 production is very high, the thyroid gland is functioning hyperfunctioning due to any cause. So much more less amount of T4 and less amount. So that is hyper functioning of the thyroid gland. Now this will inhibit an inhibitory effect. This will result in inhibitory effect on TSH will be produced, less TSH will be produced, and if the level is very high, there will be no detectable amount of TRH and no detectable amount of TSH also in the circulation. So an abnormally high level of T4 will decrease the TSH level to non-detectable limit by the conventional assays, as you will see later in my reports, in some of the reports which I will show it to you. Is this part here? So that part is written here. So in a schematic diagram, in a pictorial diagram, see schematic diagram, say this is thyroid gland, and this is pituitary, and this is hypothalamus. So there is a production of T3, T4, and it is exerting a negative effect and positive effect either way, depending on the concentration of thyroid hormone. The basic purpose of regulatory mechanism is to restore thyroid hormone levels to normal level. Next. So diseases of the thyroid, it can occur primarily within the gland. That means the gland is itself diseased, thyroid gland. There is a possibility that pituitary can also be diseased. Hypothalamus can also be diseased. In our time, when the hypothyroidism or hyperthyroidism used to occur because of the problem with the thyroid gland itself, it used to be called primary. And if the disease is due to pituitary, that is called secondary, and then if it is due to hypothalamus, it used to be called tertiary. Now, it is very difficult clinically to differentiate between hypothalamic hypopituitary hypothyroidism or pituitary hypothyroidism. So TRH test, if you give not functioning, how will you determine whether hypothalamus is working or not working, or pituitary is not working, because TSH is not present. So TRH test was not available. Here it was available in a very limited institution. So that's why it is difficult clinically and also biochemically because of the non-availability of TRH test. So differentiation classification has been changed. It is either primary, that is involving the thyroid gland, or it is central, maybe in the pituitary, maybe in the hypothalamus. Next. So some of the clinically relevant important information. So there are terms which are used for the thyroid gland. One is euthyroidism, that is normal functioning, normal thyroid status, euthyroid status. When the gland functions less, that is called hypothyroidism, and if it functions more, it is called hyperthyroidism. Whether it is hypothyroidism or it is hyperthyroidism, the aim of treatment is to restore euthyroidism. Hypothyroidism needs to be restored to euthyroidism, again hyperthyroidism needs to be restored to euthyroid state, otherwise the patient will have symptoms. So the thyroid function test is done to determine the status of thyroid functioning. This disease can be detected clinically, but when the disease is quite advanced. Nowadays, that advanced stage you will not see because of the wide availability of the investigation facility. And that is the basis of my PhD thesis conceptualization after observing this thing. And there is a huge amount of debate between the clinicians and myself in the laboratory, that laboratory report is not matching with the clinical features. And there is a huge debate. And my sister, youngest sister, on casual investigation, I will tell you in a short while. So even if you detect, diagnose, suspect clinically, that requires a biochemical confirmation. Without biochemical confirmation, hypothyroidism or hyperthyroidism cannot be diagnosed. Remember. So biochemically, this disease can be detected at a very early stage, just like diabetes. If the blood glucose level is more than 126 fasting and PP more than 200, you will tell that patient is diabetic. The patient may not have any symptom. Patient may not have any symptom. But if the fasting blood sugar level is 150 and postprandial is more than 250, the patient is diabetic. Nothing will be heard. The patient requires treatment, patient is diabetic. The patient will report symptom because when the blood sugar level is 300, fasting blood sugar level 300, 400, even at that stage patient doesn't become symptomatic because this develops over a period of time. Same thing is true for thyroid hormones also. When there is significant decrease in the thyroid hormone level, then only the patient will come with symptoms, and that is in advanced stage of the disease. When that gland is detected, at a very later stage. So it is detected biochemically with a very early stage before any symptom and sign. Before any symptom and sign, if the disease is diagnosed, that is called like a subclinical, means the patient doesn't have any symptom. And most of the patients are detected at this stage nowadays, subclinically before any symptom by casual routine investigation. Now that is the uniqueness of biochemical test for all parameters. Biochemical abnormality is found much more earlier than clinical findings, and there will be always mismatch between the laboratory finding and the clinical findings until proved otherwise. In majority of the cases, during detection, during monitoring, there will be some mismatch, and this mismatch is because of that biochemical changes takes place much earlier. Next. So goiter, any enlargement of the thyroid gland is called goiter. Any enlargement, it can be euthyroid, it can be hyperthyroid, it can be hypothyroid. So when iodine is deficient, that is called a iodine deficient goiter. Now in our country, because of the iodization of salt last 20-25 years, practically there is no iodine deficiency. So any one of you or any one of us or any one of in this region suffers from a goiter, that is not an iodine deficient goiter. And again, that was a point of debate with our clinicians in the late 90s when I joined Durgapur Children's Hospital, that's iodine deficient goiter. I argued with them, no, it's not, cannot be, because iodine salt is being consumed by the person. So that is an iodine sufficient goiter. Then the cause of iodine sufficient goiter is autoimmune disease and autoimmune thyroiditis. Next. So this is actually the presentation of the goiter in the early stage. I have shown you the enlargement of the goiter of a child that was suffering from hypothyroidism. And this type of cases I used to see, I have seen during my MBBS life, a patient presenting with a huge amount of goiter. These are neglected cases. They wanted to resort to something until this is very much disturbing. They cannot deglutiate properly. At that stage, the people used to come. Now, you will perhaps not be able to see such type of cases because patients are much more conscious and healthcare facilities are available practically everywhere. And patient can go on by just looking at the gland, looking at the neck, one can diagnose whether the thyroid gland is increased or not. So, very unlikely that you will see this type of cases. In contrast, in early picture, you will get this type of cases also. The purpose of showing this thing in your questions, I have seen that clinically oriented questions are set, not biochemical questions. So, some amount of idea will be there. So, because of this problem, iodine sufficient goiter, way back in 1990, I had to pacify the 148 doctors of our hospital to write an article of environmental goitrogens and how safe we are. There are a number of goitrogens which are present within our environment, but still we don't have any goiter. So I wrote this thing in our Indian Medical Council Association souvenir in 1998. It's a complete article. If any one of you want to see this thing, I will supply this thing next. So goitrogens are substances which increases the thyroid gland. That is called a goitrogen. And a number of substances are present in the food, in the water. See, cabbage, maize, millet, sweet potato, beans, mustard seed, cassava. Every vegetable is also having some amount of goitrogen, and cabbage is the highest amount. So there is a common perception that once you suffer from goiter, you cannot take cabbage. No. Answer is no, no, and no. Because we are not food faddists. We do not take cabbage like cattle. We take cabbage as a part of curry during our lunch or during our dinner. So that amount of cabbage is not sufficient to act as a goitrogen and produce goiter. So there is no logic not to take cabbage or any of the substances which are having goitrogen substance, because this goiter which we are seeing is an iodine sufficient goiter and it got nothing to do with the goitrogenic substances. Next. So goiter was long known associated with the primary hypothyroidism, which is not the case right now. We are having iodine sufficient goiter, and that is due to autoimmune disease, and this is called autoimmune thyroiditis and not iodine deficient goiter. So treatment with the iodine will be a sheer failure, because the problem is not with the iodine, because we are having adequate amount of iodine. So never give any iodine to a patient who is suffering from goiter. Rather try to remove the misconceptions. And they try to take a high amount of sea fish that contains a high amount of iodine, and that worsens the problem. It can occur with hyperthyroidism, it can occur with euthyroidism also in the compensated state, because the TSH gland the pituitary gland is releasing a high amount of TSH to increase the thyroid cells. So thyroid cells undergo hypertrophy and hyperplasia both. And because of the hypertrophy and hyperplasia, thyroid gland increases. So that's a compensated increase, and this gland is remaining in the compensated state. So apart from that, there will be increase in the gland size due to thyroid tumor or thyroid cancer. Next. So see, thyroid disorders were on the topic was written. So basically, because my PhD thesis topic was given, and before that I appeared in the examination in 2001. So this is a thyroid book. Anyone is interested, you can see it. So nobody can have a mastery over this book. This is such a big book. This second part was this part. This is because of the large price, I could not purchase it. Honestly speaking, when I applied for PhD Viva, I had to Xerox some of 15,000 rupees in 2001 was a very costly affair for me. So this book is if you want to read, this book is available from me. You can take it, no issue. But it is very difficult to digest. So anybody having a mastery of thyroid disease want to interpret T3, T4, TSH, please show this book. That please go through this book and then come. And this is only a part of that thing. The only thing which I wanted to say, and this is again one thing I want to say, I wanted to analyze 10,000 data which I have analyzed in my laboratory T3, T4, TSH and tried to correlate if there is any correlation between T3, T4 and TSH. Unfortunately, this is a negative study. So that much work has been done also by me before. It was done in the year 2003. Next. So it's not that an easy process. There is no shortcut. So diseases of the thyroids are many. It is not covered, cannot be covered. So I have summarized this thing to hypothyroidism. Functionally, remember, functionally either it will be hyperfunctioning or hypofunctioning. And that will be a large major area of concern. Some of the hyperthyroid cases might require surgery. So that comes under the purview of the surgery. Even if you do the surgery, you need medication. So there is one called CKI thyroid syndrome, thyroid nodular disease, benign lesion thyroid cancer. Treatment is quite differentiated. I will emphasize only on hypo and hyper, not beyond that. Because this is beyond the purview of your knowledge and level. So next. So it can be primary, it can be secondary, as I told you, it can be central, primary or central. Next. So congenital hypothyroidism. See, Government of India did not make a national policy of iodinization of salt, I mean, without any logic. There is a good number of people who suffered from neonatal hypothyroidism, and the main problem of neonatal hypothyroidism is, apart from miscarriage, stillbirth, mental retardation, skeletal congenital anomalies, if this baby, newly born baby, if it remains undiagnosed, it will cause permanent mental retardation, and that child will be a burden to the family. He will not be able to do anything. So remember this point, any newborn baby, there will be newborn screening of hypothyroidism, and if there is a little bit of doubt, if the TSH level is high, or if TSH level is low and T4 level is undetectable, either do a TSH test. That is the most sensitive parameter. If TSH test is not available, then do a T4 test. If the thyroid gland cannot produce T4, obviously T4 level will be less, and immediately start thyroxine treatment to prevent neurological damage as much as possible. So there will be whatever the baby has been born with that neurological deficit, that you cannot rectify, but you will not allow permanent damage to occur soon after birth. That is the purpose. So the important aspect is that, see, if this baby is born like this, and if he is allowed to grow, the child will appearance like this, and from this appearance you can say this cannot be a normal child. A protruded tongue is there, and there is evidence of, see, this look is sufficient to show this thing, that the mentally retarded. Next, if you allow it to progress further, you will get such type of picture. Now, usually this is found in the poor families. Now, can you imagine the family? The child will be a burden to himself, burden to the family. He will not understand whatever you are saying because he will be mentally retarded child. And that is the basic reason of iodinization of salt to prevent neonatal hypothyroidism. And the sooner you diagnose, the better, and you will be able to prevent at least some amount of damage. And in the first year of life, thyroid requirement is very high, so a high amount of T4 level is to be given during first year of life, so that neurological damage is not. Those who are opting for pediatrics, those who are opting for gynae in future, they must remember that every newborn must be screened for hypothyroidism until proved otherwise, indicated otherwise. So next, in contrast, next, In contrast, adult hypothyroidism is a little bit tricky. It's not that easy to diagnose, and most of the cases are diagnosed casually on biochemical investigations, just like sugar, urea, creatinine, cholesterol, triglyceride. Because this number of these symptoms, this tiredness, weakness, dry skin, feeling cold, hair loss, difficulty concentrating, poor memory, constipation, weight gain, dyspnea, hoarse voice, none of the symptom is specific for hypothyroid. I repeat, what the patient say is called symptom, what the doctor looks, it is called a sign. So patient is complaining of dry skin and you examine and find this is dry spot skin, that is a sign. Patient is showing increased weight gain and you look for this puffy face of the hands and feet and the myxedema peripheral edema, and that is a sign. Now these will occur at a very advanced stage. And the real reason of my PhD thesis I am telling you, which will get an opportunity also in your life. One day there is one test kit was available, only one test was left. My younger sister came and I casually took the blood from her and got the investigation. I found to be grossly hypothyroid. She did not have any symptom and I carried out all the investigations for hypothyroid and all came out to be negative. And subsequently over a period of 3 years, I studied, read considerably thoroughly about hypothyroidism, and that was the basis of conceptualization of the PhD thesis for me for primary hypothyroidism in an urban community in Durgapur, and I completed this thing within 4 years time. Next. So in adult, just by looking backward, see this type of picture you will definitely get. So this is from foreign country, so you will get this type of picture. Now this type of face doesn't indicate that the patient is having hypothyroidism. You will see this type of. So this symptom will appear when the disease is quite advanced. Remember, next. The only good thing is that 100% cure is available in this case. If you replace, here the defect is thyroxine deficiency. So if you replace thyroxine orally, there will be no deficiency, and the patient has to take thyroxine lifelong. So before giving any thyroxine treatment, be sure that the patient requires thyroxine. Nowadays there is a fashion to give thyroxine to make the patient hypothyroid and to treat. For some reason or other, patient has comes for something, you start on giving thyroxine. That's a mistake. Somehow this is overused. I can speak at length on this topic. Earlier in our time, when even in the 90s, only 100 microgram tablets were available. Now 12.5, 25, 50, 75 and thyroxine levels are available. So depending on the degree of deficiency, residual damage, thyroid gland doesn't get 100% destroyed overnight. It takes years of time. So depending on the amount of thyroid tissue loss, you have to substitute that much amount of thyroxine to the patient to restore TSH level to lower half of the normal range. The trick is here, lower half of the normal range. Why? Because it's a progressive disease. There will be autoimmune, progressive autoimmune destruction. So just to prevent that thing, you are having some amount of buffer so that this TSH will be brought down to normal and preferably in the lower half of the normal limit. But do not overtreat. Do bring it down to the less than normal limit. So one important thing, it should be stored, this drug should be stored in the cool and dry place, and it should be taken on empty stomach 30 minutes before breakfast, because otherwise there will be interference of thyroxine absorption by the food, and there is a common mistake being done, and even the endocrinologists in the early 90s used to give thyroxine after breakfast, and there is a considerable fluctuation between blood T3, T4, TSH level and the clinical dose adjustment, and unnecessarily the patient used to be given 200, even 300 micrograms of iodine, and I studied that most of the patients can be treated with 100 micrograms of iodine. 5% of the patients require 150 micrograms of thyroxine in my study, which I carried out for my research work. So patient compliance is very important. Most of the patients do not take the medicine regularly. And non-compliance, non-adherence is a big problem in chronic patients. Next. So in contrast, hyperthyroidism is very easy to diagnose. From the look, you can see the eye is protruded. See, from the look, you will be able to diagnose that this patient is having some amount of hyperthyroidism, and the gland will be enlarged. Usually, this by looking at the gland, and the patient will typically complain of weight loss against increased appetite. Patient is taking food, but he is losing weight. There will be diarrhea, there will be increased palpitation, nervousness, irritability, anxiety, sleeplessness. That will arouse suspicion of hyperthyroidism, and he will be able to diagnose clinically immediately. And the patient requires also treatment. But for that, again, you have to determine the T3, T4, TSH level or FT3, FT4 level first, because that will be required for monitoring. There will be dramatic improvement if you give an antithyroid drug to this patient. So, hyperthyroidism diagnosis clinically is much more easier than hypothyroidism. Next. So, treatment of primary hypothyroidism, just like that was a replacement therapy of thyroxine. In contrast, there is no replacement. You have to block the synthesis of thyroid hormone, and that is done by the antithyroid drug. And carbimazole, in the trade name of neomacrozole, it is widely available, and it is given in the doses of 5 mg TDS or 10 mg TDS thrice daily, depending on the cases. And you need to adjust the dose, and that is given. And bethimazole is also available, and propyl thyroxine also available in 100 and 200 microgram tablets. So we can have a different combination of drugs which are available, and in a clinical practice we will select one of the drugs, and then you will give giving this drug. Again I repeat, at this stage you must remember what is the mechanism of action of antithyroid drugs. Next. So thyroid function next. So to assess the thyroid function test will be done. Next. So in reality, biochemical test, the real functional test, that is oral glucose tolerance test, is a real-time functional test. You have allowed glucose to be administered, and periodically after half an hour, 1 hour, 1.5 hours, you are taking blood and measuring that level. That is a real-time test. In contrast, thyroid function test is not a real-time test, but it indicates an ongoing thyroid status of an individual. We collect the sample at a given point of time. I mean, are you in a hurry, or can I complete this class, because I will take a little more time? I mean, how many of you are in need of going to the next class? Can you spare 10 to 15 minutes time? Just do this thing, I will complete this thing, this will complete the lecture. Next. So that is again, so this real-time test is done by, that is a radioiodine uptake. We allow the radioactive iodine to be ingested, and that iodine is taken up by the thyroid gland, and that dynamic study is done by the nuclear medicine department, and that is called thyroid imaging. Next. So if you do this thing, radioiodine uptake, there will be radioiodine uptake. This thyroid gland, you can look this. The radioiodine will cast an image, and this is a normal functioning gland, and this is Graves' disease, the hyperfunctioning gland, and this is basically adenoma. So this is done by the nuclear medicine department. Of course, I tried to develop this department in biochemistry itself, but unfortunately it did not materialize as early as 1993 at DSP hospital. Next. So biochemical assessment, this part you remember, because that will be asked. These three tests, T3, T4 and TSH, is the commonest investigation done for thyroid, and free thyroxine and free thyroid T3 is also done. So that will make the complete investigation. Next. Just a 5 minutes there. Here you know this important, but the normal level. So one thing you must know, that the common parameters, you try to know the normal level, because every time the normal level will not be written, and in the examination the abnormal report either low or high will be given, and you have to interpret. So all the parameters, be it cholesterol, triglyceride, urea, creatinine, you see the lower limit and upper limit, the difference is usually not exceeding more than 2. And even in this case of T3 and T4, you see that the lower limit and the upper limit is 2.5 times, it is 2.75 times, T3 and T4 level it is 1.72 times, 1.8 times. And that one thing again I remember, that T4 is just in the 10 to the power minus 12 in picogram level, and TSH level, this is present in the T3 level in the This T4 is level in the microgram level. So there is a 10 to the power minus 6 difference. Can you imagine the difference? There is such a high difference of concentration is there, and this is 10 to the power minus 9, 10 to the power minus 6, 10 to the power minus 12. So it is operating between 10 to the power minus 6 and 10 to the power minus 12. Gram concentration, that regulation is there. So TSH is the main determinant of thyroid hormone, and you can see that this is the only parameter in the body which is having such a wide margin between the lower limit of normal and the upper limit of the normal, and that is 15.5 times, and the liver laboratory different ranges. But you see the range is more than 10 times at by any laboratory. And why is this range? Next, one thing is not known by many, and you must know this thing, the relationship between FT4, which is the controller of TSH secretion, and the TSH. Remember, you have worked in the only 10 log graph paper, that is 10, 0, 10, 20, 20, 30, 40, 50, again on this side 10, 20, 30, 40. But this is a semi-log paper, where in this axis it is a linear axis and this is in the logarithmic axis. So this is 10, 100, 1000, 10,000, 1 lakh, 10 lakhs. So FT4 is having an inverse log linear relationship with TSH. So slight amount of FT4 change will cause significant rise or alteration of TSH level, and that is the reason why it doesn't match. আরে এটা তো হবে না, এটা তো সম্ভব না, এই ভ্যালুর মধ্যে এই জিনিসটা হয় নাকি, এই রিপোর্টটা ভুল আছে। No, no and no, because this also haunted me, and I had found in the research paper is not available in the textbook, and this is the crux of the problem of creating confusion between the doctors and the doctor and patient, because they don't know this thing. Next, a test done, everything is normal, all these 4 parameters are normal. This is basically euthyroidism, all parameters are less, it is in the hypothyroidism. Next, so single test, if it is allowed, given a choice, everybody cannot afford everything and every facility is not there. So a single test is wanted for any hypothyroidism or hyperthyroidism. The choice of the test is TSH. A high value will indicate a primary hypothyroidism, a low value will indicate a hyperthyroidism. But only thing is that if the pituitary and hypothalamus is defect, then there will be low TSH. So if T4 and T4 are available, and that is biologically active, if 2 tests chances are given, you do for TSH and FT4, that will confirm hypothyroidism and hyperthyroidism, because in either case, either TSH will be low or TSH will be high, and FT3 can be low or normal, or it can be low or normal in either cases. So if 3 tests choice are given, then you go for TSH, FT4 and FT3, because there is an element called T3 toxicosis. When there will be hyperthyroidism, obviously T4 and T3 will be increased, but FT3, T3 is increased much more in T3 toxicosis. And if you know the complete picture as a whole, then you do all the 5 parameters, and usually on an initial screening, I prefer to do all these 5 tests to have a baseline level. Next. So limitations of T3, T4, TSH, that is something I'll tell if there is small group discussion. TBG level is not done commonly. So next. So remember, if FT3 and FT4 TSH is normal, all these 3 are normal, but total T3 and T4 is high, it can be low. If the T3 and T4 is high, take history first, what drug he is taking, and normally in most of the ladies this disease occur, and ideally they are on oral contraceptive or they are having a pregnancy, and that is the reason why total T4 level or T3 level is high, with the increased TBG level that is acting as a reservoir, and that gives a false erroneous representation of high T4 level, but T3 and T4 level, but not TSH. So the main cause of high T4 and T3 is increased TB level due to any cause. Similarly, if the total T4 and T3 is low, it will decrease the TBG level. It can be decreased due to decreased albumin level, or we are taking several drugs together and that is displacing the T4 and T3. Next. So whether this thyroid is having a autoimmune basis or not, for that we require to determine anti-TPO antibody, that the body is mounting an immune response against its own element, that thyroid peroxidase enzyme is there to basically make this thyroid hormone. So if anti-TPO antibody is there, then this TPO will not function. So anti-TPO antibody measurement is a routine part of the evaluation of hypothyroid patients. Serum thyroglobulin is measured for the thyroid cancer patients, and TSH reports at care centers. Next. Importance of this test is to diagnose this hypo and hypothyroidism of the confirm or exclude. And next. So after the treatment has started, you have to need to monitor whether the level has been restored to normal level or lower half the normal level. We have to titrate, and for that, and patient adherence. Patient doesn't take medicine properly, all the patients. For that, you require to monitor at different time intervals. Next. So radioimmunotherapy is the most gold standard method, and that is the method which I used to adopt from 1992 to 2007 in our laboratory, and this is the gold standard throughout the world. And later this enzyme-linked immunosorbent assay and chemiluminescence immunosorbent assay, about which I will take a class later in a small group discussion. I will discuss in detail. Next. So while interpreting, first look at the TSH level, whether it is normal, it is high or low. First look, T3, T4, TSH level. Interpret. If then T4, if T4 is done, else T4, whether it is normal or high or normal. And then if T3 is done, else T3, normal, high or low. Next. This you take a little photograph if you want, I will allow it, because this you must remember. See, it doesn't develop overnight. So euthyroidism means everything is normal. Primary hypothyroidism, this is based on my experiences. In early stages, subclinical means the patient doesn't have any symptom. In that case, a T3, T4, TSH, FT3, FT4, everything will be normal. TSH will be high, because there will be compensatory mechanism which will be active to restore everything normal, and that is the reason why you are seeing everything to be normal. In the later stages, as the disease advances, first T3, T4 will be low, and then total T3, T4, total T4, and in that case TSH will be very high. Just similar to that, hypothyroidism, in the early stage, T3, T4, FT3, F4 will be normal, but TSH will be low. But again, as the disease progressive, FT34 and FT will be high, and then total T34, T4 will be high, and TSH will be very low at this stage, and it will be undetectable. Next. So after this thing, there will be a question, and you have to answer this type of question. Try to concentrate this thing. Say a 21 years lady, because this is I had no intention to make this question, but keeping in view of your first professional examination, I am a little worried that you are not having a clinical orientation, but clinically oriented questions are given. So look at this question, the catch point here. A 21-year lady presented with goiter, means thyroid abnormality. After investigation, the following were found: serum T3 0.9, I have delivered it in normal range. T4 is 1.8, TSH is 118, anti-TPO antibody is positive. What is your diagnosis? 2 marks. Comment about levels of each. Again, 2 plus 3. Secret biochemically, the basis of your comments of each parameter, how much FT4 level remain in free and active form in the total form, and how TSH level is regulated in normal individual. And that this type of question will come. Or as explain why TSH level is high in primary hypothyroidism, while TSH level is low in primary hypertension. I had several more important cases, but because of the restriction of the time, I am closing the session right now. If you are interested, I can have a class also later. Okay, close it. So, interpretation of the report, if SGD is done, this part is covered. So, I will exclusively discuss on the reports, and there you must be able to interpret the reports of T3, T4, T6. Read this book thoroughly, and those who have heard this, my lecture, I think they will be able to diagnose the case completely.
So today's topic is interior of the cranium, okay, base of the skull mainly. We will discuss the three cranial fossas, anterior, middle and posterior cranial fossas, okay. Change. So the cranium is the skeleton of the head. Okay, so cranium is the skeleton of the head and neurocranium is the bony case of the brain and meninges. It is formed by a series of 8 bones. Okay? And अच्छा আমাকে ব্যাগটা একটু এনে দেবে, এটা মনে হয় ব্যাটারি শেষ হয়ে গেছে. Cranium is the bony case of the brain and the meninges, okay, and it is formed by a series of 8 bones. So which bones are forming the cranial cavity? Unpaired and paired bones are present, okay. So see here, this is base of the skull, okay. So this anterior most bone, this is frontal bone. Here one butterfly shaped bone is present, that is sphenoid, okay. In the and this small part is formed by the ethmoid bone. Here are the 2 temporal bones, 2 parietal bones, and posteriorly there is occipital bones. So all these bones are together forming the base of the skull. And ethmoid bone is relatively, it forms a minor contribution. See there, the pink colored bone is the frontal bone, small green colored one is the ethmoid bone. Ethmoid bone, here its presenting parts are crista galli and the cribriform plate, okay, and foramen cecum is present between the crista galli and the frontal crest. Then the yellow colored bone, you can see here butterfly shaped bone, that is sphenoid bone, okay. Then light green colored one, that one is the temporal bone. Violet one is the 2 parietal bone, and posteriorly this part sky blue colored one, this one is the occipital bone, okay. So these bones are forming the base of the skull and the 3 cranial fossas, okay. So cranium is divided into 2 parts mainly, neurocranium which is containing the brain and the meninges, and the viscerocranium. Viscerocranium is forming the facial skeleton, okay, facial bones. So neurocranium, when it is cut, it is divided into 2 parts, calvaria and basic cranium, okay. Calvaria is this one, okay, or skull cap, okay. It can fit like this. So calvaria and basic cranium, so this part is the base of the skull or basic cranium. We will discuss today the basic cranium mainly. Next. So these are the bones forming the 3 fossa. Anteriorly there is anterior cranial fossa. Behind the lesser wing of the sphenoid will be the middle cranial fossa, and behind the petrous part of temporal bone will be the posterior cranial fossa, and we will also discuss the foramens in each of the fossa. Okay. Next. Here also you can see the 3 fossas. Okay, see here, this part is the anterior cranial fossa. Here is the lesser wing of the sphenoid, 2 wings, 2 lesser wing and 2 greater wing of the sphenoid, and this part is the body of the sphenoid. So here this part are the middle cranial fossa, and here is the posterior cranial fossa. Okay, so 3 cranial fossa we will discuss, and this large foramen is the foramen magnum. And see the position of other foramens. See here, in between this mid part is the crista galli, okay, and here is the frontal crest. In between the 2 one foramen is present here, that is known as foramen cecum. On the two sides of the crista calli, one sieve-like structure is present containing multiple foraminus. These are known as cribriform plate. Okay, and this gives passage to the olfactory nerves going to be entering into the olfactory bulb. After that, here in between the lesser and greater wing, here is the optic canal. Okay, important foramens. Optic canal, it gives passage to the optic nerve and ophthalmic artery. Then there is three canals are present, foramens are present. In front is foramen rotundum, then foramen ovale and foramen spinosum. Contents of which we will discuss. And here near the apex of the petrous tempora, here is foramen lacenum. Okay, and at the junction of occipital bone and the petrous part of temporal, here is the jugular foramen. Okay, and on this surface, on this medial surface of the petrous temporal, one foramen is present, that is internal acoustic meatus. Okay, and this large foramen is foramen magnum, and here lies the hypoglossal canal. Hypoglossal canal gives passage to the hypoglossal nerve. Okay, understood? Next. So, cranial cavity is a space enclosed by neurocranium and that contains the brain and the intracranial portions of the cranial nerves and spinal nerves and blood vessels, meninges and CSF. The base of the cranial cavity is divided into three distinct fossas, namely anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Three different color code has been used. Okay, this pink one is the anterior cranial fossa, this bluish one is the middle cranial fossa, and violet one is the posterior cranial fossa. Anterior cranial fossa is at the highest level and posterior cranial fossa is at the lowest level. You can see from here. Okay, this part is the anterior cranial fossa, it is lying at the highest level. Then the middle cranial fossa, posteriorly this is posterior cranial fossa lying at lowest level. This is anatomical position. So, in the anatomical position they lies at different levels. Okay, next, see anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Next, these three fossas you can see. Next, okay, now we will discuss the individual fossa. First, the anterior cranial fossa. It is the shallowest of the three cranial fossa and formed by the frontal bone anteriorly, ethmoid bone is the middle bone and the lesser wings of the sphenoid posteriorly. These three bones are forming the anterior cranial fossa, and greatest part of the fossa is forming the orbital plate of the frontal bone. It is forming greatest part of the fossa, and what is its function? It support the frontal lobes of the brain and form the roof of the orbit. এই তোরা দুজন কি কথা বলে যাচ্ছিস তখন থেকে? সামনে আয়, সামনে। The frontal lobes of the brain and form the roofs of the orbit. Next is crista calli. Crista calli is thick median ridge of the ethmoid which projects superiorly, and each of the ridge is the sieve-like cribriform. On each side of the crista calli there is sieve-like cribriform plate of the ethmoid and olfactory bulbs of the brain which lie on the cribriform plate. Okay, olfactory nerves, actions of the olfactory nerve passes through the foramen in the cribriform plate and they enter into this olfactory bulb. Next we go to the different foramina in the anterior cranial fossas. First is foramen cecum. Here is the foramen cecum. Site is at the base of the frontal crest. This is frontal crest. Frontal crest is ending here and crista calli is starting. Okay, so in between these two, here is the foramen cecum. Okay, what it gives passage to? It gives passage to emissary vein of the frontal bone. Okay, in 1% of cases, and other cases it does not give passage to any structure. Next is anterior and posterior ethmoidal foramen. Okay, here these are the locations of anterior and posterior ethmoidal foramens. They give passage to the vessels and nerves of the same name. That means anterior and posterior ethmoidal vessels and nerves. Okay. Next is cribriform foramen. This on two sides of the crista galli, here is the cribriform plates. Within the plate there are multiple foramens. These are known as cribriform foramina. Actions of the olfactory cells in the olfactory epithelium, they form the olfactory nerves. These olfactory nerves are passing through this cribriform foramina. Okay. Next, after anterior cranial fossa, we are going to middle cranial fossa. See, these parts are the middle cranial fossa. Butterfly shaped middle part is formed mainly by the body of the sphenoid, and on the two sides the greater wing of the sphenoid, temporal bone, squamous part and petrous part, and parietal bone. Okay. So, butterfly shaped fossa, middle cranial fossa, bounded by in front by the sphenoidal crest of lesser wing. Here, this is known as the sphenoidal crest of the lesser wing, and part of the body of the sphenoid. Here, this part of the body of the sphenoid, behind superior border of the petrous part of the temporal bone and dorsum celli. Here is the superior border of the petrous part of the temporal bone and dorsum celli. Here is the dorsum celli. Laterally by the squamous part of the temporal bone. Here is the squamous part of the temporal bone, and it communicates with the orbits by the superior orbital fissure. Here, one longitudinal fissure is present, retort shaped mainly. Okay. This lies mainly between the lesser wing and greater wing of the sphenoid. We will see in the bone. So, via these superior orbital fissures and also the optic canal, these are communicating the middle cranial fossa with the anterior cranial fossa. Sorry, middle cranial fossa with the orbit. Okay. Next is these are the important features. Sphenoid crest, they end medially in two sharp bony projections. Here, these two bony projections, these are known as anterior clinoid processes. Okay. Optic canal is lateral to the sulcus chiasmaticus. Here lies the optic chiasma. Okay. Optic chiasma, and these foramens on the, and so this sulcus is known as sulcus chiasmaticus. Okay. And here these foramina are optic canal. Optic canals, via the optic canal passes the optic nerve from the orbit and enters into the brain, which transmits the optic nerves. And centrally, the floor of the fossa is narrower, formed by the sphenoid bone, which contains the sphenoidal sinuses. So, this part is the body of the sphenoid. Okay. And the roof of the sphenoid sinus, within the body of the sphenoid lies the sphenoid sinus, and roof of the sphenoid sinus is deeply concave. Here lies a depressed fossa. That's why roof of the sphenoid sinus is concave. Okay, deeply concave, and it houses the pituitary fossa, pituitary gland. That's why it is named as pituitary fossa or sella turcica. Okay, sella turcica here, and this lies between the tuberculum celli in front. These are the tuberculum celli, and dorsum celli behind. This is dorsum celli, and the projection on the two sides of the tuberculum celli, these projections are known as middle clinoid process. Okay, and this projection on the two sides of the dorsum celli, these are known as posterior clinoid process. Okay, and this between the tuberculum celli and dorsum celli lies this hypophyseal fossa or pituitary fossa or sella turcica. Okay, and that gives attachment to the tentorium cerebelli, and these projections, this anterior clinoid process, this tuberculum celli, dorsum celli, all these are giving attachment to the tentorium cerebelli. Okay, this is a extension of the dura mater, tentorium cerebelli. Next, what are the foramens lying in the middle cranial fossa? First is optic canal. Here lies the optic canal. Optic canal lies within the lesser wing of the sphenoid. near the root of the lesser wing of the sphenoid. Structures passing through this foramen is the optic nerve and the ophthalmic artery. Next is superior orbital fissure. It lies between the lesser wing and the greater wing of the sphenoid. What are the structures passing through this foramen? Oculomotor, trochlear. Oculomotor is third nerve. This is fourth nerve. Lacrimal, frontal, nasociliary and abducent nerve and superior ophthalmic vein. All these are passing. Abducent is sixth cranial nerve. All these are supplying motor supply to the extraocular muscles, third, fourth and sixth. So, they will pass through this superior orbital fissure and also the superior ophthalmic vein. Ophthalmic artery is passing through the optic canal and vein is passing through the superior orbital fissure. Okay. And lacrimal, frontal, nasociliary, these are branch from with trigeminal nerve. Next is foramen rotundum here. Just posterior to the superior orbital fissure, this rounded foramen is the foramen rotundum, round foramen. Bone, it lies in the greater wing of the sphenoid. And what are the structures passing through it? Maxillary division of the trigeminal nerve. Okay. Ophthalmic division is passing through here, through this foramen, superior orbital fissure, which is giving these branches. Lacrimal, frontal, nasociliary. These are branch from ophthalmic division. Okay. And so, this foramen rotundum, it gives passage to the maxillary division of the trigeminal nerve. 3 divisions we have read in the lecture. Next. So, foramen rotundum, it gives passage to the maxillary nerve. Then foramen oval. Foramen oval, it gives passage to male structure. You can remember like a mnemonic. Okay, M-A-L-E. M is the mandibular nerve. A is accessory meningeal artery. Then L is lesser or superficial petrosal nerve. And E is emissary veins connecting the cavernous sinus with the pterygoid venous plexus. Next is foramen spinosum. It gives passage to middle meningeal artery and the nervus spinosus. Okay. So, these are very important, very frequently asked. If you are asked to hold this base of the skull, you will be asked the structures passing through these foramens. Okay. You remember the structures. Optic canal is important, superior orbital fissure is important. All these 3 foramina are important. Okay. Structures passing through these foramina are very important for base of the skull. Next. So, foramen oval. See, this one is one was foramen rotundum. Okay. Here is foramen oval, oval shaped foramen. It lies in the greater wing of the sphenoid and structure passing through it is the male structure, mandibular nerve, accessory meningeal artery, lesser petrosal nerve and emissary veins. Then foramen spinosum, posterior to it here is the foramen spinosum. It lies in the greater wings. Okay, this is not, then structures passing through it is the middle meningeal artery through the foramen spinosum. Next is the foramen lacerum. Okay, foramen lacerum lies near the apex of the petrous part of the temporal bone here. It between the petrous part of the temporal bone and the sphenoid. Okay, here lies the foramen lacerum. Through it passes the internal carotid artery. Okay, internal carotid artery. It has a L-shaped course within the petrous part of the temporal. So, it is entering through this foramen into the cranial cavity. Then it is lying on the 2 sides of the body of the sphenoid here. And then it is dividing into branches. Okay, internal carotid is dividing into anterior and middle cranial artery. Okay. Next we go to the posterior cranial fossa. Okay. So, it is the largest and deepest of the 3 cranial fossa. See, this is petrous part of temporal. From here, whole of the part is the posterior cranial fossa. It contains the cerebellum. See, this depression is for cerebellum, pons medulla oblongata, here this depression over the clivus, this part is known as clivus, formed by the basiocciput and basisphenoid. Okay, this part lodges the brainstem, midbrain, pons and medulla from above downwards. Okay, so mostly by the occipital bone on sloping surface of the basilar part is called the clivus, over which lies this brainstem part, mainly pons and medulla oblongata. Next, what is the boundary of the posterior cranial fossa? Bounded anteriorly by the dorsum celli. Here is the dorsum celli and superior border of the petrous part of the temporal. Here is the superior border of petrous part of the temporal. Corresponds extracranially with the posterior part of the cranial base. And most prominent feature is foramen magnum. This large foramen here within the posterior cranial fossa is the foramen magnum. Okay, this must you have to identify, foramen magnum and structures passing through it. Next, so another is jugular foramen. Here lies the jugular foramen. So the jugular foramen lies at the junction between the petrous part of temporal and the condylar part of the occipital bone. So the jugular foramen at the posterior end of the petro-occipital fissure, petrous part of temporal and occipital, that's why petro-occipital fissure. Jugular foramen upper border has a notch for the glossopharyngeal nerve. Posteriorly, it is grouped by the sigmoid sinus. See this groove, you can see this groove is for the sigmoid sinus. Okay, sigmoid means A-shaped sinus, which continues into the foramen as the internal jugular vein. Okay, it passes through the foramen, then continues downward as the internal jugular vein. Then jugular tubercle lies between the inferior petrosal and sigmoid sinus. Here lies the inferior petrosal and here lies the sigmoid sinus. So here is the jugular tubercle. Okay. Next, আগেরটা যা হ্যাঁ এটা বাকি আছে। Next is sigmoid sinus. Sigmoid sinus, it runs forward and downward, finally forward to the jugular foramen. Here this groove, whole of this groove is for the sigmoid sinus. Then median internal occipital crest, this midline crest here, this is known as median occipital crest. In the squamous part of the occipital bone gives attachment to the falx cerebelli. Falx cerebelli is dural fold separating the two cerebellar hemispheres. Okay, and in this part it is grooved by one sinus that is known as occipital sinus, and the groove for the transverse sinus runs laterally from the internal occipital protuberance. Here lies the internal occipital protuberance. From here runs laterally. This groove is up to here. This groove is for the transverse sinus. Okay, runs laterally from internal occipital protuberance, and internal occipital crest separates two shallow fossa which houses the cerebellar hemisphere. This crest is separating these two fossa. This is one fossa and another is lying here. Okay, in this region. So two fossas are for the cerebellar hemisphere. Okay, and this crest is forming a triangular flat area in the lower part, that is known as Vermian fossa. Okay, this Vermian fossa, it lodges the vermis of the cerebellum. Vermis of the cerebellum, it connects the two cerebellar hemispheres. Okay, understood? This is Vermian word is coming from the worm. Worm is known as vermis. Okay, it is vermis is connecting fibers for the cerebellum. Next we go to foramen magnum. See this large foramen is the foramen magnum. Bone central area of the floor. Okay, lies in the central area of the floor of the posterior cranial fossa. What are the structures passing through it? This is very frequently given. Medulla oblongata and its meninges, covering meninges. That means 3 layers of meninges: dura mater, arachnoid mater, pia mater. Okay, ascending spinal parts of the accessory spinal nerves. Spinal accessory is the 11th cranial nerve. It formed by its cranial part and spinal part. Spinal part is entering into the cranium and joining with the cranial part to form the 11th cranial nerve, which is coming out through the jugular foramen. Okay. 9th, 10th and 11th cranial nerve is coming out through this jugular foramen. So, ascending spinal part of the accessory spinal nerves and two vertebral arteries. Vertebral arteries are also entering. Then there is hypoglossal canal here. Here just above the condyle there will be the hypoglossal canal close to the anterolateral boundary of the foramen magnum, and structures passing through the hypoglossal canal is the hypoglossal nerve. Okay, understood. Next is internal acoustic meatus. Here this opening, this foramen you can see lies within the petrous part of the temporal bone, that is known as internal acoustic meatus. Okay, it is lying on the posterior surface of the petrous part of the temporal bone, and structures passing through it is the 7th and 8th cranial nerve. Okay, 7th is facial nerve, vestibulocochlear is 8th cranial nerve. These two are passing through this internal acoustic meatus. Then they are entering into the middle ear cavity. Okay, after passing through this area, facial nerve is coming out through the stylomastoid foramen. Okay, middle ear cavity is lying within this petrous part of temporal. Next is jugular foramen. Here is the jugular foramen between the petrous part of the temporal bone and the condylar part of the occipital bone. Structures passing through this foramen is the glossopharyngeal nerve, vagus and spinal accessory nerves, and the internal jugular vein. Sigmoid sinus is continuing as the internal jugular vein. Okay, so these three nerves, 9th, 10th and 11th, glossopharyngeal, vagus, spinal accessory, coming out through this jugular foramen. Okay, next. So these are the structures passing through different foramens of the posterior cranial fossa. Now we will go to the clinical aspects. Okay, in case of fracture of anterior cranial fossa in head injury, it causes anosmia. Anosmia means loss of smell sensation. Okay, loss of olfaction due to tearing of the fibers of the olfactory nerve. Okay, due to break in the cribriform plate. There will be periorbital bruising. Okay, and CSF leakage from the nose. Clear fluid will continuously coming out through the nose. Okay, and if you soak it with a handkerchief, it will be hardened after some time, because CSF is containing protein and glucose, these things. Okay, so this is an important clinical aspect. If some fluid is coming out in an injured patient, you have to check whether it is CSF. Okay, or mucus. If it is mucus, it's okay, but if it is CSF, then it is a dangerous situation. High chance of retrograde infection from the nose, okay, to the cranial cavity. There is high chance of meningitis. Infection is passed through the cribriform plate into the meninges. Okay. Next, if a blow to the chin with mouth closed, causing fracture of the middle cranial fossa. Okay. In closed mouth, if you give a blow near the chin, it will lead to break of the middle cranial fossa. Okay. Important foramens are present in the middle cranial fossa, you have seen previously. Those structures may get injured in case of fracture. Okay, and the chance of injury to the posterior cranial fossa is very less because bones are thickened over here. Okay, occipital bone, the condyles are present, they are protecting. Okay, so these are the clinical aspects. Okay, now see here, this is the, see this is base of the skull. Okay, it is divided into 3 cranial fossas. See, this part is the anterior cranial fossa. It's bounded anteriorly by the frontal bone, posteriorly by this crest, sphenoidal crest. Sphenoidal crest are the posterior submargin of the lesser wing of the sphenoid. Okay, and these projecting parts at the lesser wing, these are the anterior clinoid processes. Okay, these two are the lesser wing. Here is the sphenoid spine. This part is body of the sphenoid, and here is the greater wing of the sphenoid. Okay, so this part is anterior cranial fossa. You can see this is formed by orbital plates of the frontal bone anteriorly, this lesser wing of the sphenoid posteriorly, and in the middle this part is the ethmoid bone. Okay, and in the ethmoid bone, this projecting part in the midline, this is known as the crista galli. Okay, and this crest here, this is frontal crest. Okay, in between this frontal crest and crista galli, here is one important foramen here. This foramen is known as the foramen cecum. Okay, foramen cecum position you have seen. Sometimes emissary veins can pass through this foramen cecum. And now on the two sides of the crista galli, here two sieve like plates you can see, multiple foramens is present here. This is known as the cribriform plate. Okay, these foramina are known as cribriform foramina. This cribriform foramina gives passage to the olfactory nerves. Okay, and on the lateral margin of this cribriform plate, at the junction between the orbital plate of frontal bone and the cribriform plate, here lies two foramina, anterior and posterior ethmoidal foramina. You can see them also from this orbit, anterior and posterior ethmoidal foramina, and they give passage to the anterior and posterior ethmoidal vessels and nerves. Okay, so anterior cranial fossa is done. Next we go to the middle cranial fossa. So you can see in the this is anatomical position. Okay, how will you hold it in anatomical position? This lower margin of the orbit and upper margin of the external acoustic meatus will be lying in the same horizontal plane, that is known as Frankfurt's plane. Okay, so you hold it like this. This will be the anatomical position of the base of the skull. Okay, what is Frankfurt's plane? Sometime asked in your viva. Okay, you remember it. Lower margin of orbit, upper margin of external auditory meatus lying in the same horizontal plane. Okay, next we go to the middle cranial fossa. So you can see this highest in position anterior cranial fossa, not that much depressed. Okay, then these two are the middle cranial fossa, and this is posterior cranial fossa. Posterior cranial fossa is lying lowermost. Okay, so medial cranial fossa, it is bounded anteriorly by the sphenoidal crest, posteriorly by the superior margin of the petrous part of the temporal bone. So which bones are forming this fossa? You can see these are the greater wing of the sphenoid bone, greater wing of the sphenoid bone. Next, this is petrous part of the temporal bone. Here is the squamous part of the temporal bone, and in the upper part here it is formed by the parietal bone. Okay, so all these bones are forming the middle cranial fossa. Now you can see near the root of the lesser wing, here the root is joining the body. This is body of sphenoid, two lesser wings, two greater wings. Okay, where these lesser wings are joining with the body, these foramina are present. You can see here these foramina. So you can see these foramina are leading into orbit. Okay, these foramina, these are the optic canals. You can see it is coming out through the orbit. Everyone has seen. Okay, so these are the optic canals, gives passage to the optic nerve and the ophthalmic artery. Next, just below this optic canal, at the junction between the lesser wing and greater wing, here you can see one retort sepate foramen here. Okay, elongated oblique foramen here. This one larger foramen, this is known as superior orbital fissure. You can see it is also coming out into the orbit, superior orbital fissure. Here also on this side also, this superior orbital fissure. Okay, here is the optic canal above, and this is superior orbital fissure. You have to know the content of superior orbital fissure, third, fourth, sixth nerve or superior ophthalmic vein and the branches from the ophthalmic division of the trigeminal nerve. Okay, LFT, lacrimal, frontal, nasociliary. Okay. Next, posterior to it, this rounded foramen is present here. This this is now this foramen. This is known as the foramen rotundum. Okay, foramen rotundum, it gives passage to the maxillary division. Ophthalmic division is passing through superior orbital fissure entering into the orbit. Then foramen rotundum gives passage to the maxillary division of the trigeminal nerve. Okay, after that this oval foramen here, this oval foramen is the foramen oval. Okay, foramen oval gives passage to the male structure. Okay, mandibular nerve, third division of trigeminal, mandibular nerve, then accessory meningeal artery, lesser petrosal nerve, L and E is the emissary veins. Okay, and after just behind this foramen oval, a small foramen is present here. This one is the foramen spinosum. Okay, this foramen you can see here and here, just behind the foramen oval. Small foramen is the foramen spinosum. Okay, it gives passage to the meningeal arteries. Okay, accessory meningeal arteries mainly. Okay, next we go to the foramen lacerum. It is see here, this one near the apex of the petrous part of temporal, here is the foramen lacerum. Okay, at the junction between the petrous part of temporal and body of the sphenoid and greater wing of the sphenoid. Okay, it gives passage to the internal carotid artery. Internal carotid artery enters through this foramen here, then it passes through the petrous part and here through the apex it is coming out, entering into the cranial cavity. After entering into the cranial cavity, it lies in this groove. Okay, groove for the cavernous sinus, in the floor of the cavernous sinus, internal carotid artery, and then it is in the anterior part, it is dividing into two branches. Okay, so this foramen lacerum, it gives passage to the internal carotid artery, main content. Okay, so we have discussed the foramina of this middle cranial fossa. Now we go to the posterior cranial fossa. This is posterior cranial fossa. It is bounded anteriorly by the superior border of the petrous part of the temporal bone. Okay, and here by the dorsum celli. This part is the dorsum celli. Okay, here these structures you see. Here is the sphenoidal spine. This part is known as jugum sphenoidal. Then here is the one groove that is known as sulcus chiasmaticus. After that, these elevations are known as tuberculum celli. On the two sides of tuberculum celli, middle crinoid process. Then this depression is the hypophyseal fossa or pituitary fossa. Then here is the dorsum celli. Dorsum celli, two projection on two sides are the posterior clinoid processes, and anterior and posterior clinoid process are connected by the interclinoid ligaments. Okay, and this middle and anterior clinoid process, they are sometimes connected by anterior clinoid ligaments. Okay, now so this boundary of the posterior cranial fossa, dorsum celli, superior border of petrous part of temporal bone, and posteriorly the occipital bone. Okay, so we will see the important foramens here. In the middle, this foramen is known as the foramen magnum. Okay, it gives passage to the medulla oblongata, which is continuing downward as the spinal cord. Medulla oblongata, and it's covering meninges, vertebral arteries. Okay, and this spinal root of the accessory nerve. Okay. Next, just above the foramen magnum, here you can see these are the two condyles of the occipital bone. Just above the condyles, here lies the hypoglossal canal. See, I have placed the wire in the hypoglossal canal. Okay, this is hypoglossal canal just above the condyle. Okay, through it passes the hypoglossal nerve or 12th cranial nerve. Okay, next here at the junction between the petrous part of temporal bone and the condylar part of the occipital bone, this foramina is the jugular foramen. Okay, on the two sides it is present, jugular foramen. Sometimes the jugular foramen is discussed by dividing into three compartments. Okay, anterior compartment gives passage to this three cranial nerves, 9, 10 and 11 cranial nerve. 12th is passing through the hypoglossal canal. 9, 10th and 11 glossopharyngeal, vagus and spinal accessory passing through the jugular foramen, and also the here is the position of the sigmoid sinus. Sigmoid sulcus, you can see this depression. This is for the sigmoid sinus. Okay, sigmoid sinus is also passing through the jugular foramen and continuous downward as the internal jugular vein. Okay. Another is here within the petrous part of temporal. This is known as internal acoustic meatus. Through it passes the 7th and 8th cranial nerve. 7th is the facial nerve and 8th is the auditory nerve. Okay. Vestibulocochlear. Auditory is also known as vestibulocochlear. It again divides into vestibular and cochlear. Cochlear is for hearing, vestibular is for balance. Okay. So 7th cranial nerve after and within the petrous part of temporal lies this middle ear cavity. Okay, within which lies these 3 small bones, malleus, incus and stapes. Okay, after passing through the middle cranial cavity in the posterior wall and medial wall of this tympanic cavity, it comes out through this foramen. This is known as stylomastoid foramen, lying between this styloid process and this mastoid process, stylomastoid foramen. Okay, through it comes out the facial nerve. Okay. Okay, now within the posterior cranial fossa, these 2 depressions you can see, these are for the cerebellar hemispheres. Okay, and these 2 depressions are separated by a midline crest that is known as internal occipital crest, and this prominence is known as internal occipital protuberance. Okay, from here the crest is extending downward. In the lower part, here is one triangular flat area is formed that is known as Vermian fossa and which lodges the cerebellar vermis. Cerebellar vermis is connecting 2 cerebellar hemispheres. Okay, and from this internal occipital protuberance on the 2 sides, 2 grooves are present. These are for the transverse sinus. Okay, and transverse sinus is continuing laterally and downward as the sigmoid sinus. Sigmoid sinus coming out through the jugular foramen as the internal jugular vein. Okay, and here the sagittal, superior sagittal sinus is extending up to this internal occipital protuberance. The region here all the sinuses are meeting. Okay, here along the internal occipital crest there is a depression for the occipital sinus. Occipital sinus to transverse sinus and the superior sagittal sinus and the straight sinus are meeting at this point. So, this point is known as confluence of sinuses. Okay, sinuses we will discuss in next lecture. Okay. So, important foramina is foramen magnum, hypoglossal canal, jugular foramen and the internal acoustic meatus. All these structures you have discussed. Okay, understood. So, you have to know the boundaries of all the cranial fossas and the different foramens you have to identify and their contents. Okay, and also one opening is present near the foramen lacerum, pterygoid canal, that is also asked in your viva. What is the content of the pterygoid canal? Okay, pterygoid venous plexus and the nerve of the pterygoid canal, that is known as Vidier nerve. Okay, all these questions are asked. Any queries? This is frontal sinus, and within this body of the sphenoid bone lies the sphenoid sinus. সেজন্য বলছে the roof of the sphenoid sinus is deeply concave because of presence of this pituitary fossa, hypophyseal fossa, and these clinoid processes and tuberculum celli, dorsum celli and this margin of this superior border of this petrous temporal, all this gives attachment to dural diaphragma celli. Okay, these are projection from the dura mater. Okay, tentorium cerebelli mainly, free margin and attached margin of the tentorium cerebelli. Okay, this clinoid processes gives attachment to tentorium cerebelli. Sigmoid sinus is it? This one is sigmoid sinus for the which is sigmoid venous sinus, which is continuous downward as the internal jugular vein. Okay, transverse এখানে ছিল transverse sinus continues downward as the sigmoid sinus, sigmoid sinus continues as internal jugular vein. Okay, বোঝা গেছে? And along the internal occipital crest lies the occipital sinus. Here will be the superior sagittal sinus. Okay, understood? And here will be the petrosal sinuses, superior and inferior petrosal sinus. Along the superior margin, superior petrosal sinus. Along the inferior margin, inferior petrosal sinus. Okay, and on the two sides of the body, here will be the cavernous sinus, and these two cavernous sinuses are connected by intercavernous sinuses. Anterior and posterior intercavernous sinuses are present, and here also one sinus is present along the this margin. Okay,
একটা ছিল ফোরামেন ছিল যেটা এই অপটিকের
কি foramen? This is the optic canal. এটা optic canal আর এটা হলো superior orbital fissures. Okay, annulus of gene বলে একটা, this is a fibrous structure which is dividing the superior orbital fissure into three parts: medial, lateral, intermediate. Okay, all these parts you have to know which part is transmitting which structure. Okay, any queries?